I'm an obstetrician and I specialise in maternal and fetal medicine, so that's a subspecialty of obstetrics. It deals with mothers with high-risk pregnancies and abnormalities and babies with abnormalities. So if there's a congenital abnormality, they come and see us at the hospital. I'm also a clinical lecturer at the University of Otago, and I also do a bit of my own obstetrics as well. So today, there's quite a broad range of topics, and the first one is intrahepatic cholestasis of pregnancy, and we're just talking about itching in pregnancy and how to manage it and what it means for the mum and the baby. I thought we'll talk a bit about assisted reproduction and pregnancy outcomes, but it's quite a short, brief topic, so I've also added a little bit more, which ended up being a little bit of a special interest of mine, and it's more about advanced maternal age and pregnancy outcomes. And I think with IVF you always tend to think about advanced maternal age, and it's not necessarily specific to IVF that I'll talk about, but more what does it mean for the older mothers when they're pregnant. And then something that's quite relevant lately is the short cervix and progesterone. And progesterone has sort of snuck up on everyone as this medication that helps with preterm labour, and for years we're using cervical cerclages beforehand to try and hold that pregnancy in, and progesterone has really changed the management of preterm labour or women at risk of preterm labour, so I thought we'll talk about that as well. So the first, just some cases to have in the back of your mind while we're discussing what it all means, but the First Lady, this is a classic presentation of a woman in her first pregnancy. She's about 32 weeks, somewhere in the middle of her third trimester. She has an itch, a bit itchy on her hands, a bit itchy on the soles of her feet, and it's slowly spreading. It's not that bad, it's just irritating. She just wants to know what it is. Maybe she's finding it a bit difficult to sleep. We do some blood tests, and the bile salts are slightly raised at 15, and her liver functions are mildly increased. Then you might get this other case, which is a bit more rare, a 34-year-old, 2 previous pregnancies. She's 26 weeks, she's got an itch everywhere. She's had it earlier than other pregnancies. She's had it in both her previous pregnancies. She's got steatorrhea, which is fatty bowel motions, dark urine. She's a bit tired, unsurprisingly, because she's itching all night and she's not feeling very hungry. Her bile salts are incredibly raised at 45, and she's got moderately deranged liver function tests. So what we want to know is how to manage these women. Which one is the worst prognosis? Are they different? Does it matter that this one seems to be more mild or that one seems to be more severe? Should they be managed the same? And are there any risks for the baby? So, as I implied, presentation is an itch, a real irritating itch. That it starts on the hands, the palms of the hands and soles of the feet, and it just spreads to the trunk and the limbs and eventually to the abdomen. It starts in the 3rd trimester, and it can be earlier if you've had a effective pregnancy before, or if you've got twins or triplets, any multiple gestations. It's associated with abnormal liver function tests and raised bile salts, and I'll talk to you about the difference of those later in the diagnosis, but it's a little bit controversial as well. Really, steatorrhea, dark urine anorexia, and even rarer jaundice. The incidence is widely quoted about 1% across populations, but it varies according to geographical region and ethnicity. So in South America, Chile's quite a predominant one. Up to 1 in 20 pregnant women have been reported to have this. And interestingly, it's worse in the winter months. So there's a seasonal variation. There are well-known risk factors, and these risk factors here are associated with an earlier onset. So if you've had a previous effective pregnancy, multiple pregnancy, twins, triplets or more, if you're hepatitis C positive. IV for some reason, slightly higher rate, but it looks like in those populations they have a slightly higher rate, and that may be due to the advanced maternal age as well. And there's a genetic variation. I'll talk a bit about that later. There's some genes that's been identified with the transport of bile in pregnancy. There are some associations, so those that have intrahepatic cholestasis are more likely to have gallstones. It's more likely to come about if they've had prolonged emesis, so prolonged vomiting or nausea in their pregnancy. And the women who report themselves as to be more sensitive to drugs, so they're sensitive to the contraceptive pill, the Mirena, they can't really take much medications. These are the ones that are thought to develop intrahepatic cholestasis. Vitamin D is a huge hot topic, and it's unsurprising that low vitamin D is associated with this condition as well. It seems to be associated with a lot of things. So in New Zealand, low vitamin D is prevalent on the west coast, and I think most of you will know there's a Ministry of Health guideline for vitamin D in pregnancy. So we don't test for it routinely, but those that are higher risk, such as those who live on the west coast, who are indoors all day, like me, we just start them on vitamin D. Low selenium is an interesting association, and New Zealand's well known for their low selenium soils, and we don't appear to have an increased rate in cholestasis, but that seems to be an apparent. And there has been some studies looking at the supplementation of selenium to help with this, but it hasn't made any difference. It's just interesting. Oh, physiology. So a bit rough talking about physiology after lunch, but I like to keep it simple, so we'll try and keep it simple and then slowly build up. So intrahepatic cholestasis is thought to be due to a build-up of bile acids due to slower transport caused by maternal hormones. It's thought that estrogen impairs the sulfonation capacity of bile and reduces hepatocyte membrane fluidity. Now everything gets blamed on hormones, but there is a natural history. So you can tell by the recurrence and subsequent pregnancies. So the natural history of the disease supports that it only occurs in pregnancy or exposure to hormones. And also when they're looking at studies for progesterone to prevent preterm labour, there was a higher rate of cholestasis in those women. So that's something you have to be careful about when you're giving women progesterone. Also, women who've had it in pregnancy are more likely to get this condition if they go onto a contraceptive pill. So, here we go. There's a liver. Let me do this. A liver, gallbladder. There's bile ducts in here, and they all sort of drain into this common bile duct, go out through into the duodenum. So the liver makes bile, and biles, you've all seen bile, greenish yellow, and it contains bile acids as well as other stuff, and it contains bilirubin. So the liver passes bile into the bile duct, and the gallbladder acts as a reservoir for bile. So when we eat, the gallbladder squeezes bile back into the common bile duct to help digest the fatty acids in your food. So it goes down that way. Up there, down, and down, down. So that's my simplified version of it. When you get intrahepatic cholestasis, there's a reduction of bile flow, down these ducts. So it doesn't flow as well. And it's thought that the bile leaks into the bloodstream, and that's what causes the itch in these women. If you want to get more complicated, you can go into the cellular level, and this is the sort of thing you memorise before you sit your exams, and then you promptly forget about it. But this is a cell, and then a canalicular thing, so everything goes into the area. So this is schematic looking at the homeostasis and synthesis of bile acid, and it's regulated by this thing here, which is called a farnesoid X receptor, but FXR. So when the intracellular levels of bile acid raise. When they raise, the FXR is activated, but it down-regulates the synthesis and uptake, and it acts through this thing, and then it goes this way, and then the bile acids are secreted that way. And there are genetic variations for this, and this is why it runs in families. So these hepatobiliary transporters, so they transport the bile acids into the canalicular area. So it's these transporters here that are noted to have mutations in them, and that's why they get a genetic predisposition. But in intrahepatic cholestasis, this way, and that these alternative pathways are activated, which aren't normally present or not normally activated. These are the main pathways. So familial component. So we know there's a familial component because there's a familial clustering of the disorder, and it's also inherited in a sex-linked dominant fashion, and it can skip generations depending on the type of transporter protein that's affected. We know that if you've got a sister that's had intrahepatic cholestasis, your risk of developing it is 12 times, relative risk of 12. And there are 3 types of progressive familial mutations. So, and they've all got long names. So FIC1 is familial intrahepatic cholestasis 1, BSEP, bile salt exporter protein, and MDR3, multi-drug resistant 3, which is probably the easiest to remember. But these are the ones that are affected for the transport out, so that's why the bile acid builds up, because these are defective. But these ones are activated as well, so it's not all bad. So now to more interesting stuff. I really don't like physiology, but this is the better stuff, the clinical stuff. So how do we present it? We've talked about this. So there's a classical itch, resolves 48 hours postnatally, and that tends to be the key thing, and that's the thing you look at when you're thinking about other causes. You want to know it's resolved 48 hours postnatally. There's no rash, but there are excoriations from itching. Unsurprisingly, a lot of insomnia, a lot of tiredness. We've talked about that before. So liver function tests may rise before or after bile acids. There's no pattern. Sometimes the bile acids can rise first, sometimes the liver functions can. The transaminases are quite sensitive, and ALT is the most sensitive rise. ALP is not really helpful at all. ALP is naturally increased in pregnancy because the placenta secretes ALP. So you can't really, it may be elevated for them, but you can't really tell. GGT will be raised in about 20%, but usually the familial ones, MDR3 mutation, has an increase in GGT, so that may be a clue. In saying that, we don't really test for familial mutations, but it's an interesting academic component. It can take 4 to 6 weeks postnatally to resolve. Some people recommend postnatal blood tests, some people don't. I think if you're confident in your diagnosis, it'll probably just resolve by itself. But also remember to use pregnancy-specific ranges for liver function tests. The upper limit of normal for especially the ALTs will be lower. So there are different tables for those. There's an increase in bile acids. It's controversial as to whether the bile acids should be fasting or random. Most places will do it fasting now, but a lot of studies will be mixed. So the main thing is to exclude other causes and always look at the bigger picture and look for clues with the diagnosis as to what it could be. You know, it may be intrahepatic cholestasis, but it may be something else. It may be that you've done a blood test and the liver functions are slightly abnormal and they don't have the symptoms, and it may be easy to say it's intrahepatic cholestasis, but because of the lack of clear diagnostic markers, it's better to exclude other causes. Acute fatty liver of pregnancy is a very rare liver-related disorder which is obstetrically provoked, but it's life-threatening. Diabetes insipidus is the key to this disorder. women will drink litres and litres and litres of water a day, and they have this insatiable thirst. HELP syndrome, hemolysis, elevated liver functions and low platelets of pregnancy, high blood pressure, and also check your bloods. PUPS, papules and urticarial plaques of pregnancy syndrome, or PUPS, the classic rash, blisters, and they start off in the tummy and spreads, and they have a rash. Also exclude the non-obstetric causes, the hepatitis, and for any abnormal liver function tests without other causes, it's always quite good to do these things. So Hep A, B, C, viral serology, EBV, CMV, make sure there's no other problems. Is it liver related? Is there a primary biliary cirrhosis? Hopefully you would have known that by now. Biliary obstruction, gallstones. Or is there a hepatic venous thrombosis? So investigations are supposed to be to help you support your diagnosis of intrahepatic cholestasis, but also to exclude other causes. So do your liver ultrasound, do your viral serology, do your liver autoantibodies. And it seems like a lot of bloods to do for something you know what it is, but occasionally something will be thrown up. So this is my blood workup when I do it. So liver function test, fasting bile acids, full blood count coags. Sometimes the coagulations can go up because you're not absorbing as much soluble fats, viral serology, and then the antibodies. So why are we concerned about it? So the majority of the risks are related to the elevated level of bile acids which are present in the fetal compartment. Those with the more severe end of cholestasis are more at risk, so the ones with the bile salts over 40, and that tends to be what comes out in the studies. So the most alarming risk is the higher rate of stillbirth. And I'll talk a bit more about that because it's quite worth talking about. There's a high rate of fetal distress and meconium. And in animal studies, bile acid stimulates gut motility and therefore promotes meconium release. So always monitor the baby in labour. There's a higher risk of preterm delivery, both iatrogenic, we've induced the woman because she's got cholestasis, and also spontaneous preterm delivery. There's a higher rate of respiratory distress syndrome. This is independent of the preterm delivery. They don't know whether it's due to the bile acids, whether the bile acids have irritated the lungs, or whether it's a meconium aspiration type syndrome. Fetal complications increase proportionally to the bile acid level rises. So there's a 1 to 2% increase in additional risk for every millimole per litre rise in bile acid, so about 1 to 1. So 1% risk for every increase 1 to 1 millimole rise for bile acid, and that comes across in a lot of studies. Maternally, there's a risk of PPH due to low vitamin K, and there's a higher rate of operative delivery. So the mechanism of IUFD is not completely known, and it's thought to be related to the bile acids. The ones that have the stillbirth tend to have coexisting conditions such as gestational diabetes and preeclampsia. No one knows how that interrelates, but they have a unproportionate rise of stillbirths in these conditions. So this is where it's come from. There's a clustering of stillbirth around about 37 weeks. You can see that there, so there's that rise, that's 37 weeks there, there's that clustering through there, and they through epidemiological studies, and it's led to the routine practice of induction of labour from 37 weeks. There's no randomised controlled trials evaluating that, and there never will be, because it's embedded in current practice. But that's why. So the theory of bile acids are mostly from animal studies, but also observational studies. And it's noted that there's a dose-dependent relationship, and I sort of implied that before, but this is the original study that describe that relationship. So Glantz, they're a Swedish group, and they noticed that it was only, the adverse outcomes were only significant, statistically significant, if the bile acids were over 40 millimoles a litre. Now this has been confirmed in a lot of other studies since then. It's quite a controversial statement to say, but a lot of other things have been considered, and because of that there's been a question about whether we should be conservatively managing those with bile acids lower than 40.
Excuse me, what are you talking about there with the dose dependent? What are you talking about?
Of bile acids, dose dependent, so the higher the level of bile acids, the higher the risk of outcomes. So the lower dose, you have a low outcome, a low risk of adverse outcomes. But as the dose of bile acid increases, there's a higher risk of adverse outcomes. The mechanism has been postulated that it's thought to be a vasoconstrictive event, maybe on the placental chorionic veins, maybe on the myocytes, maybe due to a coronary artery vasospasm provoking a fetal arrhythmia. Again, these are all animal studies. The fetal arrhythmia was postulated because those that have intrahepatic cholestasis, there's a slightly higher rate of neonatal arrhythmias at a high dose level of bile salts. So management, weekly liver function tests, bile acids, fetal surveillance. Now, I think we do a lot of fetal surveillance for this just to make us and the patient, just to reassure everyone. CTG weekly to twice weekly, ultrasound like a volume and Dopplers. There's weak evidence to support it. It's thought that the IFDs are acute events, so there's no evidence to say that it will improve outcomes or reduce the rate of stillbirth. And we'll talk a bit more about the medications, and vitamin K administered from 32 weeks or from diagnosis, whichever's later. Consider induction of labour from 37 weeks, continuous CTG in labour, and active third stage because of the risk of PPH. It's thought that if you deliver by 38 weeks, the fetal demise rate's reduced from 11% to 0.2%. So medications, there used to be quite a few that we use, but now the list is slowly reduced. First of all, the symptomatic relief. So it doesn't treat anything, it doesn't alter the prognosis. Menthol cream, aqueous, put it on your skin, and hopefully the itch will be a bit lessened. Refrigerate it, keep your house a bit cooler rather than warmer. Have lukewarm showers rather than hot showers, that sort of stuff. Sedating antihistamines only to help sleep. Hopefully it will reduce the itch, but there's no evidence it does. It's more the sedating effect you're after. But this is the main one, ursodeoxycholic acid. Now this is it's a natural bile acid. It's a tertiary bile acid, and it's present naturally in small amounts of human serum. The action of it is poorly understood in this case, but it's thought to be due to upregulation of these areas, MDR3 and BECP, to help the excretion of bile acids. Doses are quite big dose, 1 to 2 grams a day in 3 divided doses, and it's titrated to symptoms, so you sort of start off at the lower end and work your way up. It improves maternal symptoms by 80 to 90%, and it's one of the few drugs that will improve the bile acids and liver function tests. And it has been shown to reduce the bile acid levels in maternal serum and also the fetal compartment, so the umbilical cord serum has a reduced level of bile acids as well. They've also done amniotic fluid studies which have reduced levels too. And it's thought that because you're reducing the bile acids that the placental function's improving as well. side effects which are common to all drugs: loose stools, nausea, vomiting. But in fact, the loose stools, some women will stop that medication because of that. The nausea and vomiting we can cope with, but the loose stools, some of them find it a bit too much.
So it's treatment of symptoms, not a cure?
No, nothing, there's no cure.
So
Delivery's a
it's
cure.
reproduction and stuff.
Yeah, delivery's a cure. It doesn't alter the prognosis. The aim is to prolong the pregnancy, yeah. Vitamin K, which I alluded to before, but start from 32 weeks. And the aim is to reduce maternal and fetal bleeding, although there is lack of data to support that vitamin K does make a difference. We do give it anyway. Some people will give it only when there's the coagulation goes off, and some will give it when there's signs of malabsorption, like steatorrhea. Rifampicin is an interesting one. This has only just started being used in refractory cases of intrahepatic cholestasis. It's in those cases that monotherapy has been unsuccessful, and it's used frequently in the management of primary biliary cirrhosis. In pregnancy, it's a category C, so there's no risk of congenital abnormalities, but there is a risk of harm to the mum and baby. And the risk of harm is due to prolonging the thrombin time, and so there's a higher rate of bleeding in mum and baby near term. So to mitigate the effects, you give vitamin K. So if you're using rifampicin, you're giving vitamin K anyway. So how does it work? It enhances the bile detoxification and excretion and bilirubin conjugation. And that's through MRP2, wherever that's gone. This one here. Have a go. Yeah, there we go. So this is the pathway it works on. So if you remember, ursodeoxycholic acid worked on this pathway. So rifampicin works on this pathway, so it's thought to be synergistic, is that the word? So it enhances this one here. It also converts bile acid to a more hydrophilic species, so through this here, so it's more easily secreted as well, and also we're upregulating through here. That's all I had to say. It also improves symptoms and biochemical markers, and it's a once-a-day dose. Dexamethasone was used as a second-line therapy, and in a lot of older guidelines, college guidelines, there will be reference to it still. We don't use it as much anymore, and it's thought to act on the placental level by suppressing fetal estrogen production, so you're reducing the maternal estrogen levels and therefore reducing the severity of cholestasis. Originally, it looked pretty good. It looked like there was a partial clinical and biochemical response of up to 70%, so people thought this was fantastic, but it's never been reproduced. That was the only study, so no one uses it anymore. Significant side effects, and we do put women on dexamethasone for other reasons. Babies with arrhythmias, we treat the mum so the baby doesn't have it. Restlessness, bad dreams, sleeplessness, reduced fetal movements. I really worry about the movement of the baby because the baby's movements go off. And also glucose impairment. If you've got gestational diabetes or pre-existing diabetes, the blood sugars are very hard to control on this medication. High doses, 12 milligrams once a day. Cholestyramine. Now, I remember prescribing this as a house surgeon, and it's a nasty little powder thing, and they drink it, it's thick and it's unpalatable and people don't like it. It's supposed to absorb the bile, may relieve itching. No improvement in symptoms, not really. No improvement in liver function tests, and no improvement in bile salts, and in fact it may reduce the absorption of fat soluble vitamins as well. Okay, so that's all the medication we have. We used to have quite a bit, and we used to think that it works. Now we've been reduced to 2 or 3 things. Risk recurrence. So when we're talking to the woman about this, in the next pregnancy, 90% chance of getting it again. But it may be a bit lower if they had a multiple gestational pregnancy, so if they had twins. They usually get it earlier, and for each pregnancy it's earlier and earlier. And also they should be warned if they go on the contraceptive pill that they could get a recurrence of it as well. And so maybe that they should be considering non-hormonal contraception.